Okay, can you now see a PowerPoint slide?
Yes.
Okay, great. Let me know if there are any issues with audio or with the video as well, and I will just get started. So the topic of this meeting is just an introductory level discussion on what is autism, how does that look, and kind of how is it diagnosed, as well as what are some risk factors we know about for autism. And then I'm hoping to have later sessions where I can get into intervention strategies or age-specific or needs-specific kind of ideas. So this is very introductory level. And like I said, I'll overview some characteristics of autism with you, which you probably already know about, talk a little bit about how it's diagnosed, and then list what we know as contributing factors in the research so far. Feel free to comment, question, jump in at any time. And the rationale for getting an introductory level out there to all kinds of people is that those numbers have really changed over the time that I've been presenting on autism. I've had to update that number, the estimate from the CDC on the number of kids who autism affects. I've had to update that almost pretty frequently, coming down from 1 in 250, down, and now we're looking at 1 in 68, with the numbers being higher in boys than girls. As far as characteristics of autism, I really like this visual. That's a quick summary of those main 3 areas that are affected in almost all kids with autism spectrum disorders. And that would be communication, social skills, and restricted interests or repetitive patterns of behavior. And when those 3 align, that's when we typically see a diagnosis of autism or the presence of autism. I would throw out sensory needs in there too, but those can certainly fall into the repetitive behaviors as well. And it's important to note that sometimes 2 of these areas will intersect and we may have a different disorder. Some kids who are deaf and hard of hearing may have some deficits in communication and social skills for different reasons. You know, some kids with obsessive compulsive disorder are going to have restricted interest or repetitive behaviors and deficits in social interaction for different reasons. Some kids with anxiety disorder or ADHD might have these components, but it's when those 3 kind of align is what we typically see for autism. And from the CDC website, I really like this page that I'll show you. Hopefully the screen sharing works correctly for me. That kind of overviews in a reader-friendly format, I think, some of the red flags. So looking at those little ones around 18 months, social skills, communication, unusual interests and behaviors, some other symptoms, so maybe that's where the sensory piece falls in, their process of development, and then the way the symptoms can really range. Because in the past, we had several diagnoses that fell under this umbrella, like PDD-NOS and Asperger's syndrome, and in the current DSM-5, that's not the way it's diagnosed anymore. But it is important to note how much variation you can see from kid to kid. So let me know if you are seeing my browser opening up here. Are you still on the PowerPoint, or can you see the website?
Website.
Great, yay.
Yeah.
I love this technology then. I still doubt it, but I love it. Okay, so this is something I like to share oftentimes with teachers, that overview signs and symptoms. And I like over here on the right, the example of range of symptoms. And that's important in looking at things like intelligence can range from disabled to gifted and still have the same diagnosis of autism. Same with social interaction. You have kids who completely avoid all social interaction. And then you have kids who really want to form friendships and might be overly social to an inappropriate degree because they're really seeking that out. I had a student several years ago who, her family owned a dry cleaning business, and every time someone would come into the dry cleaning business, and this was in a large city, she would hug them. And so that's an example of, yeah, she was a social butterfly. However, it wasn't really setting appropriate. She wasn't picking up on the cues that not everybody wants a hug when they pick up their dry cleaning, or expects one anyway. Same thing with communication. We've got lots of kids who are nonverbal. We've got kids who are hyperverbal, those who might previously have been diagnosed with Asperger's syndrome that talk like little professors, and use those words like actually and at a young age and correct you at a young age. So I'll scroll down a little bit. You get the idea, but the same range is happening with behavior. Sensory needs and sensory seeking and sensory avoiding, and motor skills can be just as various as they would be in any child. So I don't like to read to people, but this is a good resource if you would like to look at it later, that's listing red flags, especially for those younger children. And then deficits that can happen in social skills. We know those typical ones like a lack of eye contact or preferring to play alone. But some of these can apply to older kids as well, like has trouble understanding other people's feelings or talking about their own feelings. And one thing I will see a lot of times is these kids have a deficit in taking the perspective of others, or even knowing that another person might have a perspective or a frame of reference or an experience that's different from theirs. And then going to the next level of taking that information to modify our own behaviors is even harder. I see a lot of, I don't know, maybe around 5th grade, these kids who are pretty verbal but have some autistic-like traits. Election season is a really sticky one in like small group speech therapy, where these kids have their opinion on a candidate and they don't understand that other people may disagree or have parents who disagree. I believe that communication is always affected in this disorder, and that can look delayed, late talking. That can look like regression, like, yeah, my 1-year-old was saying mama and now he is not. That can look like being hyperverbal to the point where the conversation is dominated, especially like at the high school level when we have those restricted interests. I've had students who only want to talk about tornadoes. And yeah, if we can shape that interest into learning how to have small talk about weather in the gas station or other settings, great. But when someone will only talk about tornadoes all the time, they're not going to get a lot of interaction, especially from strangers, because it's not going to look typical. Intonation can vary from very flat, monotone speech. I've worked with a lot of kids on not sounding like a robot, but I've also worked with a lot of kids on not sounding like you're singing when you're talking. So again, the range is huge, which is why I like that visual with the 3 circles to remind us of the overlap of those areas. And unusual interests and behaviors, they're not always unusual, but they're often restrictive and repetitive. I know an adult who is very, very concerned with like the moisture level in his soil when he's farming, to a point where when other people are talking about farming in a generic way or in a variable way, that he will only talk about moisture levels. And so that falls into the communication piece, but also the restricted interest piece. And some of these we perceive also as sensory needs, like the classic hand flapping or body rocking is kind of like, okay, it is a repetitive behavior, but what need is it meeting? So I'm probably spending too much time on this page, but I do like sharing it. Okay. Any questions or comments about things you've seen in individuals?
Not really.
Okay.
No, I'd agree.
Yeah, I have a couple students on the spectrum, but things are going pretty well.
Good. This is a short video about early signs. I think it's 2 or 3 minutes, maybe 4, and let me know how the audio is.
The earliest signs that are being identified now, especially in children under 1 year of age, and this is being done through sibling studies, through following siblings of children diagnosed with autism who we know are at greater risk for autism, following them at 6, 12, 18 months of age, and at 2 years of age determining do they have autism, and if they do, what did they look like at 6 months? These things are very subtle, and they revolve around eye contact and facial affect and very, very subtle things that I think would be difficult even for parents who have another child with autism to pick up on. Videotapes have been used too to look back at first birthdays and see what did this child look like and what was their eye contact and facial affect and joint attention like. Did they seek the attention of other individuals by looking to their face and checking their facial expression? Did they gaze reference? Did in a novel situation, somebody new comes into the room, did they look at their mom and check her reaction to see if it was okay? Very subtle things. When those things are not developing, especially easier to detect past 12 months of age, they are cause for concern. And probably the simplest way that a child over 12 months of age will manifest that kind of joint attention piece is by pointing and saying, I want you to look at something that I'm looking at. And not just pointing at it and looking at it themselves, but pointing, looking at it, looking at you, looking back at it to say, I want you to look at that. That communication loop is enormously important. No words, no vocalization sometimes, although sometimes and between 12 and 15 months, we want to see that in typically developing children. But it's an easy thing to miss. So by 18 months, if you're not using words functionally, meaning you're not just repeating them from TV, but you're not using a word to get somebody's attention or make a request, and you're not doing a communicative gesture like pointing and gaze referencing, then that's a high cause for concern. Other big area of concern that is promoted frequently is that if you have had a communication skill that you lose, and about 1/3 of children with autism by history will have some language that they lose. That can also be very subtle and insidious and easily missed. And in retrospect, parents go, yeah, you know what, they did say mama, dada, and bye-bye, and now they don't anymore.
So that's one I like. That channel on YouTube has quite a few videos that are great when we get into more detail about implementing interventions or using visual support. So I do like that. That's from the state of Ohio. Now we can talk a little bit about the diagnostic process. Autism is diagnosed either in a medical model using the DSM-5 criteria, or in Iowa we do in what's called an educational diagnosis, looking at 6 areas. So the DSM update here of the 5 from the 4 is a little bit streamlined in some ways. But again, it's just basically looking at deficits in those big 3 areas: social communication, social interaction, across contexts, repetitive behavior, communication needs. And then what they're doing from the DSM-5 is then adding a note about severity level: mild, moderate, severe, profound type things. So that's what a physician would use to make that diagnosis. As far as what we've done in school sometimes when it's a need is taking into consideration these big 6 areas and determining if there are academically relevant significant deficits across these areas, then we may look at an educational diagnosis, looking at communication, social participation, the repertoire of activities, interests, and imaginative development, developmental rates and sequences, sensory processing, and cognition as well. Any questions on those?
Who makes the determination on the educational diagnosis?
It is a team approach where you would likely have people involved with expertise across those areas and gathering input from other professionals and family members who know the child and see the child in multiple settings, like teachers and parents. But from our end, you would want your psychologist or social worker or behavior strategist involved. You would want a speech language pathologist, and then often it's the academic strategist or special ed consultant or early childhood special ed teacher. I like to involve an occupational therapist in looking at the sensory needs. I feel like I'm forgetting somebody, but you get the idea that we probably should not be just, unilaterally indicating that someone has autism without looking at the whole picture with a whole team.
Okay.
Here's another short video on the importance of early intervention.
Recent studies suggest 1 in 6 children has some developmental disability.
Grades is over grade.
For Connor Osborne, that disability is autism.
We really didn't know where to start.
We always say the earlier, the better. The younger the person is, the more pliable they are in terms of learning.
The process starts with screening. In Connor's case, there were language delays. But upon referral for further evaluation, the wait list was more than 6 months and 50 miles away.
I think it's a huge impact to be able to offer to a family a service that they can rely on, and knowing that it's well done, it's comprehensive, it's standardized across the state, it's available to them at the time that they want it and in the place that they want it.
So ADEP's next step is to train local teams to evaluate children suspected of having autism using the latest internationally renowned evidence-based tools and teaching methods.
Having something local is absolutely critical.
They appreciate that it's here locally, that they don't have to wait 3 to 6, and in some cases a year or more to get into a clinic. They can get an answer faster. If we didn't have that answer, I would feel I wouldn't know where to go. And we can provide the parents with a faster response, and we can get the children into the therapeutic programs that they need to be in.
Oh no!
Once a child is diagnosed, the Play Project enters the picture. Local intervention teams like this one in Greene County show families how they can be part of the treatment process.
Yum, yum, yum.
Using toys to teach.
And you do it through play because that's what kids his age do. I mean, that's the way they learn, that's the way they interact. Home is the most natural place for that to happen.
It's basically a relief. It gives me something I can do to help work on the issue. They helped fill in those gaps, and that really made a world of difference in my life. It was just because, okay, so now I know how I can behave around him.
In Ohio, developmental screening rates have increased 50%. Diagnostic wait times are down. Parental satisfaction is up.
A miracle. Just from where he was to where he is.
It matters. It matters to start early. It matters to have folks who are trained and have the capacity to do this. And it matters to connect the systems. As we're connecting our systems, we are leading nationally.
If you're on the fence about getting involved in the ADEP program, please do it, because autism is on the rise, and more kids need this intervention. They need this diagnosis so that parents have the tools that they need to help their children. Oh, thank you. If you don't get involved, people are going to miss out.
And no, we are not in Ohio, and no, we don't have identical systems in place, but I really like the emphasis in that video on teaching parents to provide intervention as well and empowering them. I think that ties in very well with our agency focus on coaching. And I know the early childhood department has a lot of those skills in parent coaching, where in older grades we are working more often with coaching teachers, and that's great too. We do not know the cause of autism right now, but there have been some risk factors that are identified, or contributing factors. Many forms of autism are looking like they have a strong genetic component. Like they talked about in one of the videos, having a sibling with autism is an indicator that the other siblings will have a higher chance of having the disorder as well. There are some other genetic and chromosomal conditions that may contribute or end up with features that look very similar. There are some certain prescription drugs during pregnancy that may be a risk factor. And that kind of critical period for development has been identified, and that's why we typically see diagnoses happening at an earlier and earlier age. There's also been research that advancing maternal and advancing paternal age are likely to contribute to autism as well. And so what I like to share with many times teachers is that this is a highly neurological disorder. And so there are structures in the brain that look different, either in shape or size or function, than in the brains of neurotypical children. And I think that's an important reminder that, you know, these kids are really interpreting their environment in a different way than other kids. And that's what's affecting what we might see as challenging behaviors or sensory needs. And here's Temple Grandin, who I got to see speak in October, and I find this quote pretty funny. I like her sense of humor. What would happen if the autism gene was eliminated from the gene pool? You would have a bunch of people standing around in a cave chatting and socializing and not getting anything done. So I think that's a nice reminder that a lot of these kids do have strong skills in certain areas, especially in many cases visual skills, or visual learning is a strength. And so that's kind of that engineering eye in some cases. And so there is obviously value to people being different. And I'm sure you've seen this quote before, but that's kind of my reason for coming to work every day, is I do believe all kids can learn, all people can learn. We just need to be differentiating and changing what we can do to help. So with that, I'd welcome any input you have or questions.
Well, let's see, I've got a student who is twice